Oh, perfect. Okay. Hi, everyone. Welcome to our February 2025 Evening Education Connection through HMS School for Children with Cerebral Palsy. Tonight, we are thrilled to welcome Dr. Mary Stevens from Thomas Jefferson University. She's speaking on our part two of a two-part series from transitioning from pediatric to adult medical care. So with that, I will hand it off to you, Dr. Stevens. Thank you so much for joining us.
Okay, cool. Julie, smile. There we go. I always have to get a picture. All right. Hey, guys. I'm Mary Stevens. So I am a family doc by training, and the co-director of the FAB Center. You'll hear more about that and go on a little tour. Next slide. I have no official disclosures, but I do hope that you approach this lecture and transition from pediatric to medical care, pediatric to adult medical care with the joy my daughter Callie does life in this picture. She is now 14 years old, and I'm on the list because I did not order 2 servings of the ranch dressing with her Chick-fil-A salad and grilled nuggets. So there you go. I hear it's that kind of day all around. So moving on. Little humor, because this work we do at home, and then outside of our home, just it's a challenge, but like I said, it's good. We love what we do. All right. So here's our objectives. I hope as we go through this and building off Lorian Gillespie's talk, who's a dear friend, you identify a goal for a successful transition from pediatric to adult medical care. Whether you're a caregiver, sometimes we've had students attend the talk, whoever this reaches, pick something. Hope you can find one easy button in this talk. So a resource that'll make the transition easier. Even if it's just the knowledge that, it's not just you, it's a challenge, but you got this. And then really, put on the calendar that first conversation you need to have about transition planning, or if you're already started, the next. So one action item. I'm all about incrementalism. So some of you may know us as JCCP. We were the Jefferson Continuing Care Program when we started in 2019. We got renamed the FAB Center. It stands for Adolescents and Beyond. So we're a primary care medical home for teens and adults with complex childhood onset conditions. We're actually embedded within a primary care practice at Jefferson at the Navy Yard. We officially launched in 2019, but we break the rules a lot, so we snuck in a few patients ahead of time. Next slide. And we do take care of several HMS alum. And so this is the entryway to our building, so it's kind of cool. We're at the Navy Yard, so we're not in the midst of Center City. We have free parking. It's fairly accessible, although some really high top vans have to park on the street. And it's multi-specialty. So downstairs we have radiology, we have physical therapy, we have audiology, we have medical subspecialties in the building, ENTs, or ear, nose, and throat docs, and GYN. So we have really, all these practices opened around the same time, and it's really been a great network of colleagues who serve our patients very well. Oh, urology, of course. So our focus is adults, but really we start in the teen years. We'll see 12 and above. Most folks come to us more 18, 19, 20, 21. But some folks come to us younger if they might have a pediatric provider who's retiring, if they relocate from out of state, or something's just not working. This is a quote from a seminal report out of Pediatrics back in 2011. And we have adopted it as to what we believe. So, optimal healthcare is achieved when each person at every age receives medically and developmentally appropriate care. The goal of a planned healthcare transition is to maximize lifelong functioning and well-being for all youth, including those who have special healthcare needs. So our goals, we want to create primary care access. We've heard lots of stories where folks have just been told, I can't take care of you. And they may have no specialty or primary care as they age out of the pediatric system. So we want to be their patient-centered medical home for as long as they need us. Some of our folks graduate, if you will, and they may have all their care needs met and the right specialists, and they're doing very well, and they might be able to transition, say, closer to home, or we keep them and call them one of our grads and just have a little bit of shorter appointment times. We really work, and I know this is as a parent, challenging at times, but we recognize many of our patients and their families are a powerful unit who work together to get things done. But we really want to make sure we hear the voice of the patient and respect their autonomy and self-determination. And we love when people bring their talkers. And I have one HMS alum who always brings me a great joke. It's lots of fun. And then we know that there's been terrific advances in pediatric care that have really changed the trajectory. So people are living longer and better with complex childhood onset conditions. But adult systems aren't necessarily built for this. And our goal is to help people maintain that trajectory. Sometimes things come up and we have to shift gears, and that's okay. But we don't want to miss out on that low-hanging fruit or basic needs to keep people being well and doing well. So we advocated within the Jefferson Health System when we got started. Jefferson and certainly my home department of family and community medicine believes primary care is important for all individuals. But we said we had to do it a little differently. So to care for a more vulnerable population, we need more time. And we also need a different kind of space, and we'll show you that as we go through, and we need a team approach. We started off as a pretty lean team, but we've really grown pretty nicely now. So we do 1 hour initial visits. There's a lot of history. If you have an opportunity to go through a transition program like the one at Nemours or CHOP, please do. They really have this amazing team that can abstract tons of medical information into a concise summary. So whether you come to us or you go to someone else, if there's the opportunity to have someone build you that summary, take it. You can always add to it and edit it, but it's just critical. Although through a lot of our programs in the region use Epic, and through Care Everywhere, we can see other specialty visits and other systems, but sometimes the documents don't have all the detail. So if you can get that summary, definitely take it. We do 40-minute follow-up visits. And we actually now have a complex scheduler who can help us do stack visits. So we see this more with some of our patients with spina bifida, perhaps who might need an annual kidney ultrasound so they can get their kidney ultrasound done in the morning. Maybe grab lunch in the cafe, or just come on up to primary care CS and then wrap around and see the urologist who's right next door. So again, number of subspecialties in our building. So you might follow up with ENT for that stubborn wax in the ear. You might see sleep medicine. So we really try to do some of that behind the scenes for folks, because we know how tough can be. Nurse Katie and I both have teenagers um, with Down syndrome, and we've kind of done that own scheduling on our own, and perhaps things have flown across our kitchen when it doesn't quite go that way. All right, next slide. So we started off literally, I was lucky to get a spot at Jefferson, and it was me and a medical assistant, and a whole lot of hope for the future. But now we have a big team. This is our 6th anniversary picture in the middle. So Dr. Hannah Facey has joined me after completing a fellowship with us as our 2nd attending physician in the middle there. And also the top right is Karen Roseman. She just won a Jefferson Health Award. It's for Martin Luther King Day, Keeper of the Dream. We have a fellow, we have medical assistants, we have a full-time nurse, our nurse Katie, and we've also built out a research and education arm. So you have Indigo and Ruby there in some of the pictures. We were very lucky. We got a visit from the Jefferson Colleges of Nursing Chief Compassion Officer Maggie. So she's showing off the back entrance. So as I said, we're embedded within primary care. So on the right is the large primary care waiting room that's shared with the GYN service. That's just too much for some of our patients. So we have a nice back exit that we can slip people through. Maggie's only visited us once. She is not full-time. We have a semi-private waiting area for those who, again, might be able to come in through the main entrance or not. If we don't have a room ready, they can wait in our semi-private waiting area. We do have a Hoyer lift that we use regularly. These are our rooms. It looks very long. It is oversized. It's not as big as it looks in the picture. We have high-low tables. We work really hard to get chair weights on individuals, so we can get weight every visit with no muss, no fuss. Certainly, if you want to come out of your wheelchair, we will assist in whatever way we need to, but for some visits, it's just not needed, and people are more comfortable. Maybe they have feeds running or suction equipment all set up. So we just kind of go with the flow. Next. So yes, our team now has grown. So I've mentioned sort of the folks on the top of the list there. We share a behavioral health consultant with the primary care practice who is available for short-term counseling, either by telehealth or in person. We've been fortunate through our funding to be able to support a fellowship. We're currently have our 2nd fellow. We have residents primarily in family medicine, but also physical medicine and rehab who rotate with us sometimes for a 2-month longitudinal rotation to really do an area of concentration with us. And then typically 4th-year medical students, the occasional very interested and motivated 3rd year. And then we've been really fortunate to develop a community advisory board. They're critical in providing impact for the work we do in research and education. They co-develop curriculum with us. They've come out when we did a series of lectures last year for family medicine residencies in the area. They came out to give talks and be on panels, and they're just terrific. And they tell us what we're doing right and what we could do better in the office, and we really appreciate them. So again, our focus is beyond the patient's at the center, but we really think being at an academic medical center, we have to help develop the workforce educate our staff, create important linkages to the community because medical care can't be in isolation. It's really kind of part of a holistic approach to a great life. So we value that. And we have lots of community partners, the ARC, Special Olympics, to name a few. And we were really excited when we met the HMS cast and crew, and have had some nice back and forth over the years. This is some of the current grants that we have funded. For the Pennsylvania Developmental Disability Council, we're going into year 3. So the information we developed and presented to area family medicine residents, we are now putting into modules and finding ways to distribute it throughout the state. We focus on best practices for care of individuals with intellectual or developmental disabilities, including communication, understanding community resources, working with an interprofessional team. So it's been a lot of fun. Our funding through HRSA is what's allowed us to do some of the concentrations for residents and medical students. And we now run a Project Echo, which is a telelearning, I'll teach, I'll learn, where we can present complicated or compelling patient cases, discuss them with, a broad audience, and also provide a didactic, again, part of making care more accessible for individuals with complex childhood onset conditions. And then we volunteer a lot. We're at Camp Pals and Special Olympics Fall Festival. We really stress creating the right atmosphere for care. So we talk to our staff and our team about person first language. We know some communities like autistics and deaf may prefer identity first. So we really, again, try to create a community of respect. And we make sure people know that the term is wheelchair user, not wheelchair bound, because gosh, especially our folks coming out of HMS, their chairs can do everything. And we don't touch them unless we're given permission. That's just a little graphic. We will fill out your Special Olympics form the day you come to your visit if you need it done, because we believe in it. Again, this is a framework of health equity, and we really try to build each patient's experience to what they need. I'll also say the family's experience. We are able to provide care for caregivers, sometimes siblings. We know there's a lot to get done on that never-ending to-do list, so we try to help out there as we can. All right, so again, talked in the beginning about trajectories. So here's just examples of life expectancies for people with cystic fibrosis. Back in the 70s, it was only 7. And this is data, it's a little old, but from 2002, where half of individuals with cystic fibrosis were 21 or older, and life expectancy continues to increase. Same thing with spina bifida and many other conditions. And I think it's fair to say why the pediatric world has been really focused on this and helped promote that growth. The adult world has been much slower to catch on. So our program is one of probably 2 in the Philly area that really focuses um, on folks with childhood onset um, complex conditions, and that's a little hard to believe. But we've started, we're building, our students and learners are passionate, and we just hope it keeps getting better and better. Next slide. So that was data from 2002, so a little sober then. I was able to be part of a CDC transitions working group in 2018, and what we discussed then was we're still a little stuck. So still doing a little bit better in terms of life expectancy, but still not really creating those systems of care that people need. So there's still work to be done, and we'll keep doing it. This is a slide that I like, shared for me from Dr. Charmaine Wright, one of my colleagues in Delaware. So transition should be gradual. You should have the help and the education you need to make it work for you and your loved ones. There should be growth. It should be therapeutic. It shouldn't be an administrative event. We know sometimes it is, and have families call us and they say, you know, so-and-so can't see me anymore because I hit this age, and we need help now. And we do our best, but that's why it's so important to start thinking about this now, and kind of plotting your own course. I think this is a resource that Lauren Gillespie shared as well. So God Transition has done amazing work on looking at the science of transition and the art, I would say. Develop some great templates and resources for you to use. Some of this, the onus is really on your care providers, but you know, you have to know what they should be doing and raise the question if it's not being raised. So each pediatric practice should have a transition and care policy. We've got some incredibly strong programs in the area who do that really well. They should be working with you, and you should be working with them to track and monitor progress toward transition to adult care. Transition readiness, you know, it's important. There's some self-reflection. There's tasks that our patients can take on, including utilizing their technology to do so. Where it often gets bogged down is identifying a list of adult providers who are willing to take on young adults. I'd say in this region, we do really well with specialties like physical medicine and rehab. And then there's some areas where it's a little leaner. But we're actually very fortunate. Our program will, you know, work with folks to be seen in a variety of healthcare systems. And we'll show a diagram out of the CHOP policy lab in a few slides that kind of tells you what that looks like. You know, this is prior to the first visit. Those records should get to the doc and the care team. If needed, legal documents around decision making, which I know you all touched on. I'm happy to take questions at the end about. Next slide. So it used to look like this, where literally people would come in with boxes and boxes of records. Don't do this. You don't have to do this. Care everywhere. If you're connected with practices with Epic is a beautiful thing. Interestingly, the way it's set up in our system, we can't import it till you actually register for your visit unless you've been seen in the Jefferson Health System before. So we kind of take a team-based approach to the first visit, where Nurse Katie goes in, does medication reconciliation. Karen, my co-director, and our social worker goes through some of the big life planning events where you are with waivers, decision making, that sort of thing. Um, and then I'm speed reading in the background and putting it together. We do a lot more reading after the first visit. Um, as you can imagine, some of these medical records are a little overwhelming. You know that because you've lived through it. Um, and sometimes it helps us to just appreciate the person first and see what they look like and all they do. And then we can get in the nitty gritty of their medical history. We also want the patient and the family to take a lead on telling us what's important, what are their current struggles, what's going well. Um, and then, you can bring things on a disc, but definitely don't do that one because there's so many security issues plugging it in. So just check wherever you're transitioning to if you need to put together a big paper packet or if they can work off a transition summary and care everywhere. So initial visit, we prioritize what needs to be done now. Are there critical DME needs, tube feed issues? We look at the transfer package. We really want to get to know the patient a little bit. And sometimes, again, we can catch up on the medical details, but we're meeting people after they've been with a well-oiled team, maybe for 16 to 21 years. And it's hard. And so we want to get the chance to understand what a good day looks for you, what a good day looks like for you to help us appreciate when things are just a little bit not right. We usually do initial visit, and then for some of our more complex patients or those with acute needs, we see them back about 3 months later. So we can kind of check in again. Typically, we see patients at least twice a year. Some we see a lot more than that. And then so ongoing care, really, it's different for every individual. And we take into account things like community support services. And for those who are ready to do more self-care, we focus on that as well. So this is what it can look like. This is a graphic out of the CHOP policy lab. I may have a slide on it, but my pearl is try to transition primary care first. Sometimes you can actually decrease the number of specialists you see because adult primary care providers may be more used to managing certain conditions. So for example, straightforward hypothyroidism or an underactive thyroid. When people come to us, they're usually done growing, so it's pretty easy to monitor that dosing. You don't need to see an endocrinologist. If you have celiac and it's well controlled, no need to really get you hooked up with a gastroenterologist right away. If you use tube feeds, well, we're probably going to want to connect you. That may not be our first step if you're well connected with your pediatric specialists. So, we love it when we can get folks in at anywhere 17, 18, 19, really get to know their primary care needs, build that trust and the relationship as they're then starting to hit some of the age limits in the pediatric setting. So typically 21 if you're at Nemours, unless you have skeletal dysplasia or congenital heart disease. CHOP can have a little bit more flexibility, which can actually be a little challenging for families who think they have more time and then the rules change. So we'll work with you, but you don't have to lose everybody at once. Again, I believe in that incremental approach and just doing a little bit at a time. So that's how it can look. we're used to patients who have multiple healthcare providers and get DME from different places, and we just kind of work through it all. And it really does take a team approach. And as we brought on new physicians and as we added our nurse Katie to the team that was once just kind of Karen and I and a medical assistant, Karen and I have been very relieved and grateful to see messages come right through to Dr. Hannah or Nurse Katie. And that's something we really strive, that multiple people are here to help you. Next slide. So again, here's the big tip, say it again, start with primary care first if you can. Health plans actually can allow you to have a first visit without changing your primary care provider officially if you're required to with your insurance plan. So that gives you a chance to audition a couple of practices and see how they fit. There's lots of things that can go into a fit. It's maybe the personality of the provider, maybe it's the insurances they take, maybe it's their hours, maybe how long is it that it really takes for you to get there. Do they offer telehealth services? What's parking like? So don't be afraid to use that benefit and see if it's going to work. So touching on decision making a little, and hopefully the things Lauren and I said are in agreement. So we know that 18 is the age of majority in most states. So I think you can't rent a car, but you can vote, marry, make medical and financial decisions, apply for credit cards, and it's expected when you hit 18, you can do this. I think all of us, when we were 18, we really couldn't do this. My husband and I in our 30s, had we not been so independent, we probably would have never ended up in a timeshare that then we had to get out of. So yes, you can be an independent decision maker, or the patient can be, but we really look at decision making as a team sport. And there's lots of tools in the toolbox to make it happen. So next slide. So again, definitely people hitting 18, it's complicated, and not just for individuals with a disability. I have a 19-year-old son who's off to college for the first time. And whoa, it's a challenge. The things I learn after the fact that are going on at school, even trying to help him schedule doctor's visits, get his new contact lenses. So we kind of have to plan for this. So options in Pennsylvania, the individual can act as their own decision maker. They can do supported decision making, power of attorney. So that is a legal document. You don't need a lawyer to execute it, but the individual, so the patient at the center, can indicate who they want to help them with medical decisions or legal issues if they are not able to make decisions. It's more complicated and nuanced than that. And while there's some simple documents you can get online, sometimes an attorney can be helpful in this to create more of a durable power of attorney, to really make sure that legalese is right for you. Some folks we know, families will have plans through their employer where they get a certain number of legal consult hours a year. For those where there might be financial constraints, there's legal clinic for the disabled. So it goes based on the income of the individual or the patient we're talking about here. Guardianship is considered the most restrictive option. and the way it is currently worded indicates that the person is incapacitated. Um, and we know from our experience, guardianship can be the right document to have in place. We also know there's differences between counties and who would be awarded guardianship. Um, we know that it may take away more rights of the individual than is necessary to help them kind of get through their day-to-day life and make medical and legal decisions. So um, it is complicated. I don't have great answers, but it is something you have to work with your team to figure out. I will say Pennsylvania is a healthcare representative state, so technically, if an individual can't make a medical decision, it would, if they're an unmarried individual, it would default to the parents. Um, but again, that can be a little tricky. So it works when you're getting in-person care in many cases, especially at a hospital for a serious illness. It doesn't work so well when you're trying to work out pharmacy benefits and the person on the other end of the phone just doesn't get that your person is not able to speak with them. Take time to learn, plan ahead. Also know that decision-making capacity can change over time. It's really hard to reverse guardianship, however. It can really be an ordeal. So, I'd say most 18-year-olds are not ready to go out and do everything on their own. They may not want to either. But we typically let them. We maybe are in some ways a little too protective of our folks with disabilities. And we don't give them enough time to grow into that role. We do really think having the power of attorney in place can be helpful because it does circumvent some of those frustrating conditions. Like, I'd love it if my adult child could give verbal permission for me to have this conversation with you about their prescription, but they can't, and their communication device isn't working. So just think about it, tool in your toolbox. Incrementalism, probably start somewhere, but no need to rush to guardianship because you might find a less restrictive option that works for you and your family. Next slide. All right, so why does it matter if we make this transition? Well, one reason it matters is because pediatric providers are definitely going to say at some point, you gotta go, and care is needed. But it's more than that. We'll go on to the next slide. So it can feel like the cliff, as people hit 21, 22, they lose supports from schools. Insurance coverage changes, even if you have Medicaid. Adult Medicaid offers different, and in some cases, fewer services. So you have to know what you're up against. So you can make this transition well, and you don't feel like you're going off the cliff. This is my daughter, Callie. They're having a great time with my husband. Some of the other folks on the Frog Hopper, not so happy. So for some folks, transition is truly a wild ride. For other patients of ours, it's a great adventure, and they're doing amazing things, and they're getting to study art at community college, and they have jobs, and they get to do things without their parents, and they're simply loving life. Um, so, don't forget to think about the good things that transitioning uh, out of school and out of pediatric care will bring. Um, but no, there's going to be some bumps. Um, so again, we can share all this information, but for you as an individual, it's personal. Um, we need again to make sure we keep that voice of the patient front and center. And as healthcare providers, we're gonna want to learn about them. Some of our folks need time to plan what they might want to say, whether they um, are able to express themselves typically, or use a communication device. So, one of the pearls is when you're going to a new practice, the individual, the patient, should come prepared to share something about themselves with the new team, create that personal bond. Um, you know, this is one of our patients who did a video for our students to show, our medical students and residents to show all it takes for him to get ready and get moving in the morning. And he also came to talk to some of our groups in person. And I found out, I knew he did chili cook-offs, but I also found out he was a hunter and he had an off-road wheelchair that his dad designed for him. And it was really cool. We all kind of light up when we see Zach's name on the schedule because we never know what he's going to tell us next. So put yourself out there a little bit. Tell us all the great things that you do. Tell us all the great things you want to do so we can help guide your care in that direction. Next slide. So we're going to share a little patient story. This is another one of our patients, and I think he's at McGee outpatient at the riverfront. There's some great programs there where people can work out. They also have a really good seating clinic. So I know many of you are attached and also get great support at HMS, but there's things out there. Next slide. So talk about a patient. So this is an 18-year-old patient of ours with cerebral palsy. She did not go to HMS, and some details have been changed to protect her identity. She came in for a new patient visit after what Dad described as a relatively stable year. She was involved in Special Olympics. She was able to tell us that she swims and that she liked backstroke. She had a bike through Preston's March for Energy, and that was something she really enjoyed. She had just gotten a new power chair, and she was able to tell us she can navigate it herself. Her brother was also with her, and he rolled eyes at that, and we had some fun with that. We talked about how she gets around. So she can walk with a walker for short distances, but had lost some skills after her spinal fusion and could no longer ambulate with a cane only. She was actually fine with that. It was not a big deal for her. She felt better overall, so that wasn't a biggie. And that's important to know. For some of our patients, going from a walker to a cane or vice versa could be a really big deal for her. It was just importantly, seizures were really well controlled. She had her last seizure 6 to 7 years ago. We know we have a pretty long wait list unless it's an emergency. to get folks into adult neurology. So we said, that's great, but let's go ahead and get you on the neurology waiting list. Um, and again, talked about her level of independence and self-care. Um, and we learned that she sometimes needs encouragement to eat. So we kind of made a note to ourselves, we needed to follow where her weight was going. Next slide. So our first visit, like I said, usually start with our social worker and our nurse, who gather a lot of important data. And they can be working on things while I'm seeing the patient, like letters of medical necessity, to make sure folks are getting incontinence supplies, and they don't run out, tube feeds are taken care of. So we take a little bit of a shift approach during the visit. I'll typically come in for a first visit. My part is usually maybe the shorter one. If somebody is medically stable, if they're have an acute issue, then of course that's going to be different. And we might get to a lot more of the routine stuff at the next visit, but we do what we need to do. And we really work on making to-do lists where it's a lot to take in, both as a patient and a caregiver. So we tend to write out instructions as we're talking to you. Again, that's a practice in our practice, but something you can ask for wherever you go for care, or you can also bring along another advocate who can sort of be your note taker. It's hard to both participate in the discussion and write things down. So, plan for that. We usually, like I said, typically we do a 3-month follow-up. Again, we really want to get to know people's baseline. We get the big issues out up front at the first visit. But what about the little things? Acne, wisdom teeth. How comfortable are you getting your blood drawn without sedation or with child-like presence? So we work through that. We have some pre-made lists that our patients and families have helped us create. Eye doctors that work well with folks, dentists. Fortunately, we have a lot of dental options in the Philadelphia area, including those with sedation. And in this patient's case, we also made sure, like I said, we got her Special Olympics form the day of. That was actually something when I worked with Lauren Gillespie, we were both at Christiana and worked in Down syndrome clinic together. We sort of made a pact that if we were encouraging folks to get involved in something in the community, and especially something like Special Olympics that often requires a physician sign off, although that rule may be changing, we get it done that day. And moving on with this patient, our complex scheduler got to work trying to get her neurology follow-up. There really was no rush to schedule her physical medicine and rehab an appointment with an adult provider. She's actually somebody who went to Nemours. She loved the team there. She had until 21. They were still talking, are they going to have to work on a tendon transfer? So no need to disturb that. We know we have ready access to physical medicine and rehab at our institution. So we told her stick with that, but neurology, it was a good time to transition. So we got her on the list. This is just to kind of wrap up. So having structure to transition from pediatric to adult medical care has been shown to make a difference. I think for patients and families, individual outcomes are so important on a broader population perspective. We think of that in terms of population health. certainly patient experience really matters. So if you have a plan, if you have a backup plan, if you follow through the steps, it doesn't have to be a painful experience. From a bigger picture standpoint, and something we are advocating for in terms of reimbursement and services, it decreases the overall cost of care. Um, which is also an important and can impact families. Um, so come up with a plan, work with a team that will help you implement it, and don't be afraid to take a step back if it's not going exactly right. Next slide. And I think just this reviews more of a summary of positive outcomes. If people want to look through it later, we think satisfaction in the patient experiences is really important. It's a lot easier to take care of yourself, and you're more likely to follow through on healthcare recommendations if you believe in the team and the team believes in you. And certainly one of the big things we want to avoid is folks ending up in the hospital or the ER or getting unnecessary x-rays, things like that. So again, resources to think about, teams to rely on in the area, including your HMS team. And I think that brings us to the end for questions. Yes. We can take down the slides, and if there's anybody left, we can have a little chat.
Audio, video, what do you want? Both?
Yeah, I got it. Thank you so much for that, Dr. Stevens. I'm very much appreciative of that. I'm actually a parent of a 16-year-old, beautiful, red-haired, blue-eyed child who is now 16 and will be 17 in November. So we are actively looking at his adult healthcare options. We are in the CHOP network at this particular moment, and he's had his whole life there. So we are actively looking at transition services, and I actually work for Jeff. So it's kind of—
I thought I recognized your name.
Yeah. So I've been actively watching your program grow, knowing that my son was growing kind of towards you guys. From a transition perspective, I'm glad that you mentioned it. It was, Will had a pediatrician we adored who actually retired. How long ago?
3 years.
3 years ago. So we inherited another very nice provider, but we are ready to kind of transition. And so you think that a good age to do that would be 17?
I think you could do it now. I mean, we go, I think I might have said 16. We do go as low as 12. But I think 16 is fine. Right now, we're in a pretty good place with our waiting list. We're booking out to the summer, but we still have availability. Until we brought Dr. Facey on for a while, our appointments were looking 18 months out. But this year with our fellow and bringing on Dr. Facey, we were able to bring, and having the complex scheduler to get everything ready for patients' first visits. We got a lot of new patients scheduled, but I think now is a good time, and we have availability.
Okay, thank you.
And I think our numbers are right on the Jefferson website, but you can always email me, or the HMS crew can track me down.
Okay, thank you.
Yep.
Yeah, I really enjoyed the presentation, Dr. Stevens. My daughter is on the cusp of being done at HMS the end of this school year.
Mm-hmm.
Um, you know, clinically speaking, she's probably one of the she has fewer complexities than a lot of the HMS students do, but quadriplegic cerebral palsy is pretty complex in and of itself. There's, she's got a baclofen pump and that sort of thing. I was considering trying to find a PCP up here in Berks County that would be a little more convenient for us. But then when I think about, our PCP is up here now, but he's just kind of like the guy we go to for an annual checkup, get shots. He takes care of a lot of paperwork for us, but all the other team stuff had been handled down at Nemours. So I'm kind of grappling mentally with whether I need to go with a program like yours or try to find somebody up here to just do the stuff that my doctor, our PCP has been doing. And he'll continue to see Chris until she's 23. So I'm kind of at loggerheads as to whether I want to, get involved with traveling down to Philadelphia for a visit every 6 months or so to continue, to follow up with that stuff. But I like the security of knowing that it's there too, so I'm just
Yeah, so it's hard. I mean, we want to see people in person at least once a year, but interval visits, if things are going well, can be through telehealth. For a lot of the requirements for us to sign off on DME forms and things like that, you have to have a patient visit within 6 months. We also have to try to stay open. We are not the Jefferson Health money makers. Our visits are twice as long, quite frankly, as primary care. And we have a bigger team, and Jefferson has supported us and, done the right thing to provide the care that's needed. But
Yeah,
we
it's
can't
really,
just fill out forms at one, because sometimes there's requirements, and two, we have to keep the doors open so we can keep growing. But
having somebody who's more conversant with some of the issues we face with, all the things you have to deal with for Medicaid, Medicare, waivers, and that sort of thing is pretty comforting. And finding somebody that Kristen would a place where Kristen would like to participate is important too. So we haven't figured out with our primary care doctor what his thoughts are, whether there's something well equipped up this way or not.
right.
He wasn't forthcoming when I asked him at our last visit if he had anybody in mind who had a good handle on this stuff. So
Yeah, I mean, I say it all the time. Karen is really the secret sauce to our program, and Katie, our nurse, to really those things you need in a timely manner and navigating the waiver system and insurance. So Karen, started off, I think, as a recreational therapist at Kencrest, worked on the insurance side with Jefferson Health Plans, then found our practice. We weren't ready for a social worker, but I was like, let me take your information. When we got funding to have her, I was like, hey, you want to write a job description? So she got to create her own job, which is kind of fun. And that's something that most practices don't have, and especially at that critical juncture, when there's a lot of different demands on the individual. So things work really well, say at HMS and the community programs you're involved in. But, if your daughter is going to go into a working environment and suddenly there's other access issues, suddenly that wheelchair isn't doing what it's supposed to. That's, I think, where sometimes our team can troubleshoot. We are looking at different models. I mean, if you visited our spot in the Navy Yard, we're tiny. Karen and I sit knee to knee, and we've got medical students and everything else in there. We don't have a lot of physical room to grow, which is why we're going to eventually have to kind of cap the practice, because we need the physical space to see people and we need the right staffing to patient ratio to do it the right way. So we are looking at other models that might be more consultative, and that would include access to a social worker, but that's still in the very much the planning phases, and we'll see how that goes. I mean, ideally, it would be great if there could be multiple fab spinoffs, and we have wonderful people we're training to do it, but stay tuned.
Yeah, that was my next question. Have you, mentored any of your the folks that have come through your practice over the years, and have they gone on to open their own practice or impacted an existing practice in the kind of way that you were hoping to see?
Yeah, so we just had our 6th birthday cake last month. But Dr. Facey, who's now my partner, she started off with us as a resident who was just kind of curious about what we did. And then, so she was the first person who kind of created our area of concentration for residents, and we made it up as we went it along. Then we kind of convinced our then new chair that we wanted a fellow, and figured out if she saw patients half the time and made a fellow salary, we could afford to have her. And then we created her first job. So she came on in July. So yes, eventually we'll be working on getting folks afar, but right now we're still trying to build our core. What's been really cool is the medical students that we've worked with who've then gone on and done residencies in other areas. And you get notes back like, hey, I finished up, family medicine at Rochester. I'm outside Philly now. Can I volunteer with you at Special Olympics Fall Festival? So we're getting there. But it takes time. And we're with some of the work we do around Fall Festival, it's been really awesome to have our College of Nursing colleagues join us and really kind of make it a all Jefferson little group there. Not all Jefferson, other people are welcome, but it's nice to have a big group from Jeff.
Thanks again. I appreciate it.
Yeah.
So, Dr. Stevens, my name is Marilyn Long, and I am a senior in the transition field because my daughter's 32 years old.
Okay.
And I'll say transition doesn't end the first time. So, and I've been to your office and I saw your partner and she's lovely. So we are in about our 3rd or 4th transition in my daughter's lifetime. And so the first question I have is about specialists, right? So we actually are patients of Dr. Wright's. We landed there probably before you had probably just left to start this practice at Jefferson. And we were struggling when we got kicked out of DuPont, and we live in the Lehigh Valley. We don't live in the Philadelphia metro area. And no one here was prepared for my daughter, literally. Like, I had to fight tooth and nail just to get to see a neurologist who denied us just a preliminary visit. And I happened to be on an advisory board at the hospital, and I had to engage the president of Cedar Crest, Lehigh Valley Cedar Crest, to intervene so we could be seen. Anyway, so my question is, and I did work with, I literally got involved with, because Lehigh Valley has a children's specialty hospital now, but there is no transition. Like, I've talked to almost all the specialists there when we were trying to figure out where do we go. And I said, where do you send your patients when they age out? And it was like crickets, even though there's an adult hospital right attached to it. So anyway, my question is about specialists though. And when I met with Dr. Facey, I've had this concern everywhere we go. So the primary care doc, you and Dr. Wright have tons of experience. You see patients like my daughter day in and day out. The specialists don't, right? The majority of their patients are not special needs patients because they are not, that's not what their focus is. So are you working to find a handful of, urology, gastroenterology, neurology, all the specialties that you need as a special needs young adult and adult? Are you working to find people who will increase the population so that's you're just sending to that core group so they can build their expertise? Um, because one of the most unnerving things as a parent of a special needs person is to be the first person that this doctor has seen the unique thing about your child, right? I've
Yeah.
never seen this before. Like I literally ask doctors, how many patients like my daughter do you have in your practice? Because I hate
Yeah.
for her to be the first one.
Yeah. I mean, I will say with some of the patients we get from Nemours and CHOP, 8 people in the world may have their disorder. So, you know, everybody is unique. I will say we do have docs throughout the enterprise. I mean, Jefferson and Lehigh Valley.
Oh yeah, they're one now, right? Yes.
But it's a new relationship, right? We're
Mhm.
Stormin and
Yeah.
Norman figuring it all out. So, we certainly have some folks at the Navy Yard that we refer to a lot, GI docs. But as our practice has grown and to Bob's point, people who come from Berks, like if you have a feeding tube and you live by Abington, you're not going to want to come to Methodist to work with interventional radiology to get it changed. If it's not a Mickey, you can pop in and out at home. So we have kind of built a very hidden, not written down pick list of providers, and we also take recommendations for our families. And I think just like all of us, I mean, very much into adult learning. People build their skill set. So I was just a regular family doc for years and years. I had a kid with Down syndrome, and found out in the delivery room she had Down syndrome after everything's fine. And it was all good till she was 6 months old and got croup and then suddenly became Darth Vader. And we kind of got told, well, she has Down syndrome. And I was like, my husband and I are both family docs, and we reacted, that's not in the differential for why she can't breathe. So like it was a transformative time for me, and actually I dug in and did it. So I think people can learn. I guess that was my midlife crisis. I finally, as a generalist, specialized a little bit. One of our GI docs has a child with autism, and she was very happy to get our referrals. One of her partners is just a really lovely guy who likes all the medical complexity, and he works well.
Right.
We have our epilepsy center at Jefferson, and they're wonderful neurologists, and they also helped us out with a patient with Down syndrome regression disorders. So suddenly I find myself giving a lecture for them to medical students during their block. So like we're building, but we're not as organic and young literally as we once were. But we are building that. We have a general surgeon that we love who just was new to the area, and he's like, this I love taking care of your patients because you don't call me for crazy reasons, and you see them back if I need you to see them and get their clearances done. So when Karen needed her gallbladder out, that's where she went. So yeah, I mean, it is part of that network, and we hope with some of the educational things we're doing throughout Jefferson, and really with this next round of funding from Pennsylvania Developmental Disabilities Council, we can build that expertise. Sometimes you have to manage up, but you've done that your whole life as professional parents. But I think a lot of it's relationship and admitting when things don't go right. Sometimes you just say, hell no, I'm not going back, and that's okay. And we understand that. And truly, having been on the receiving end when families come to me and said, you won't believe what this doctor said,
Right.
I believe you. Where are we
Right.
going to go now?
Right.
Been
Yeah.
there, done that. And that's what
Yeah.
those, initials after my name. So
Yeah. So I guess, the answer to my question is yes, you're building kind of a cohort of, because Jefferson's a huge system, right? So you're
ever
building,
evolving ever since I've come back
yeah,
6 years ago.
yeah. But I mean, you're trying to build a cohort of docs, go-to docs in all the different specialties that are saying to you, we love to see your patients and we're interested in seeing your patients. So they will build their skill set and their expertise. Um, and that's a question. So that is kind of the philosophy and what you're trying to do, right?
Very, organically day by day.
Yeah.
And relying on the network of the feedback we get from our patients and families. Hopefully at the end of the day, all people try to do the right thing. People also could use some additional skills, and we're trying to, even if it's talking about language guidelines, so that people feel welcome. The work we do with the medical students when they're undeclared, and who knows, they're going to be the next cardiothoracic or neurosurgeon. Just got to make it work and be human. And
Yeah. Yeah. I mean, it's culture shock for parents because if you come from CHOP or from DuPont, they have their clinics and all the specialties are in one area and you go there and you see everybody, right? And so they're all focused on CP if you have CP, right? And so now when you become an adult, you have to hunt and peck and find all those different specialties in different areas. And even, Columbia Presbyterian, we've gone to many, many systems. Columbia Presbyterian years ago was at the Abilities Expo advertising for their clinic, birth to death, you can stay here forever. Literally, it was when we went, it was orthopedic focused, and they really didn't have a cohort of other doctors, specialists. So I think they were in the infancy stages. But when you come from CHOP or DuPont, and then you go out there, it's makes your stomach hurt.
and we're trying to make it a little better.
Yeah, yeah. Well, I appreciate that. Can
Yeah.
you talk to sick visits? So if you're in your primary care, how does sick visits work? Do you have slots for sick visits if that's needed? Because I'm just speaking to your 2-year or your year waiting list.
That's for our new patients, because we
Gotcha.
really have to make sure we have the capacity to take care of our current patients. And every time we bring in a new patient and that huge box of documentation, it's really hard, and there's a lot that's done. So we just can't take that many new patients at once, and maintain the service we do. So we really try to answer all messages the day they come through. We work as a team with them.
Oh, there you go.
Having Katie, we really fought to have an RN, who really could make those triage decisions. Because MRAs were, when we had medical assistants, when we were short on appointments, they were fielding messages, but my head was spinning. I'd walk out of a room and I'd have 3 things I had to answer, and I was getting home 8 and 9 o'clock at night, and it just wasn't working. So we make it happen now because we have a fellow. We now are staffed 10 sessions a week, because we have 3 of us seeing patients. So we make it happen. It's prime time cold flu season.
Yeah.
And so sometimes it's the next morning, not the same day. Telehealth has given us a lot of flexibility. So we don't have per se dedicated sick slots, but we find ways to get people in. And with having a deeper team, it works. we know a lot of our patients can't go to urgent care. It's just not going to happen. Occasionally they'll see our primary care partners if we kind of prep them, and sometimes that works great. Sometimes it's just easier to see them ourselves, so we make it happen.
Thank you.
But again, that's why we really focus on, we don't want our patients to say, I will only see Dr. So-and-so, or I will only talk to Karen, or I will only talk to Katie. That's dangerous.
Yeah.
And we really trust our team, and we need our families to trust each other. I mean, you can have preferences, and if that works and it's safe, great. But we have to be able to kind of get each other's backs.
Thank you so much.
Yeah. I don't know if you hear the Titanic in the background. Callie's apparently taking her shower. I don't know if it's coming through, but
Well, thank you so much, Dr. Stevens, for joining us tonight. And we will get this recording out to families, and everybody have a lovely evening.
thanks. Bye, guys. Really appreciate the time.
Thank you
Thank
so
you.
much. Have
See
a
ya.
good night, everyone.
Bye-bye.